Okay, all right. So thanks so much. So I have a lot of slides, but I'm going to rush through a few of them. This is a very general overview of keratoconus. I'm going to try and present some what we already know and some of the new things that are in the pipeline. Don't have any financial disclosures. Everybody in the room, I'm hoping, knows what keratoconus is, characterized by central or paracentral corneal thinning. Varied presentation from a normal-looking cornea to a cornea with extreme thinning or corneal scarring. Uh, Now, we already know that keratoconus is associated with decrease in the number of collagen fibers. There is slippage of these collagen fibers, and those bridges are broken, and that's where the treatments, will come into play, which we'll discuss in a bit. Clinical presentation, as I mentioned, is usually starts early. I'm sure people who have access to corneal tomography, they have realized that the age at diagnosis is decreasing, and that's not because keratoconus is becoming more common in kids or in younger patients. It's just because we have become better in picking up keratoconus, at an early stage, which is really a good thing. Early signs are both stria and Fleischer's ring, and late signs can be Munson sign, Vazuri sign, and corneal scar. Diagnosis, many of us in this room started with VKGs or even something before that. But by the time the disease appears on VKG in the anterior float, you've already missed a few things. OBSCAN gave us an opportunity to start looking at the posterior float, and then more and more papers came out looking at the importance of looking at the posterior float for diagnosis of keratoconus at an early stage. Scheimpflug imaging, with or without combined placido disc, has basically revolutionized the diagnosis of keratoconus, specifically by its ability to look at the posterior float. You can have any number of presentations, especially if you look at the pictures from Pentacam, central cone, inferior cone, which is most common. You can have a pellucid-like picture, or you can have a displaced cone. But are we diagnosing them early enough? This is a swept source OCT from Tomei showing a normal looking cornea with average Ks of 42. If I ask a refractive surgeon in this room, would you do LASIK on this patient with a corneal thickness of close to 600 microns? You would probably say, yes, I'm going to do LASIK. And there's an ectasia screening program which shows that there's a 0% possibility this is a keratoconic cornea, unless you're looking at the other eye. This is a normal pentacam for the same patient. The other eye of this patient actually is florid keratoconus. So the first eye is now labeled as form first. Now, if I ask you the same question, would you do LASIK on the other eye? The answer would clearly be no. This is another patient with normal looking pentacam, and other eye has keratoconus. Another patient who has arterial tortuosity syndrome, which is associated with corneal thinning, but fortunately no corneal ectasia. So very important, as the previous speaker also said, it is important to distinguish ectasia from normal corneal thinning. Non-tomographic diagnosis is what we rely on more and more nowadays, using wavefront aberrations, corneal biomechanics, FTIR, and optical quality analysis system. I'm just going to focus on corneal biomechanics a little bit. We have ORA and Corvus ST available commercially that can be used to measure corneal biomechanics. We have been using Corvus ST for more than 10 years now. It basically captures corneal deformation response, and more than 4,000 images are captured per second. The puff of air basically indents the surface of the cornea, much like NCT, normal non-contact tonometry. And then there's an inbuilt software that measures the response of corneal deformation to that puff of air. We've shown that the repeatability of a corneal deformation response is actually pretty high in normal as well as keratoconic eyes. A relatively new index called Corvus Biomechanical Index. It basically combines a few indices that we can pick up from Corvus with sort of highest regression number. And then you can have one index, which is called CBI, which helps in early detection of keratoconus. It's use of AI-based software to detect cases at an early stage. And again, a relatively new software in the same machine, which combines the BAD from Pentacam or Scheimpflug imaging and Corvus, gives you another index called Tomographical Biomechanical Index, or TBI. This is the same patient that I showed you earlier where we thought the eye is normal and the contralateral eye had keratoconus. But if you do a CBI, it's actually 1.0. Anything more than 0.5 or so is regarded as abnormal. So here showing that CBI has an ability to pick up disease at an early stage when corneal tomography would not be able to pick up the disease, and specifically TBI as well. In this patient, TBI is more than 0.75, showing that it's abnormal. So to conclude for this part, it is important to diagnose keratoconus at a very early stage. If you have cases with form first disease, where you know the patient definitely has keratoconus because the other eye is keratoconic, it is important to follow up those patients just for the sake of research and see how these patients progress. This can be a useful tool in refractive surgery screening and for proper selection of cases for cross-linking. In terms of management, we have been managing keratoconus for more than 150 years. All these modalities, they treat the keratoconus, but they do not change the basic disease. And the biggest example is when we do a corneal transplantation and the patient sees better. 15 years later, the patient comes back with keratoconus or corneal ectasia beyond the graft host junction because you left that frill of keratoconic cornea in that eye. This is good old days. We published this in BJO in 2011, and you see all the options, they end up in keratoplasty. Times has changed now. New goals of management include halting progression of the disease and then visually rehabilitating the patients, specifically by using collagen cross-linking, which, if you remember my slide earlier, increases the number of bridges on those collagen fibers in the cornea and frame shifts the biomechanical properties to a better level. Especially in India and mostly in Asian continent, we have to realize the importance of avoiding a corneal transplantation. We hardly have any donor tissue. So cost effectiveness of cross-linking as compared to transplantation has been shown to be hugely better, and there's a reduction in need of corneal transplantation. This is one of the first randomized controlled trials in the world on cross-linking. I was fortunate enough to be present in Melbourne when this happened, basically showing that at 3 years down the line as compared to controls, there's a significant reduction in Kmax and improvement in uncorrected visual acuity after collagen cross-linking. For those of us who are doing collagen cross-linking, there are multiple presentations this morning. There are different iterations of the technique. You can do a conventional cross-linking, takes a long time. You can accelerate the process by increasing the energy and decreasing the time. You can also perform cross-linking in thinner corneas. The recommendation is not to touch the corneas less than 400 microns. This is a study basically showing that there's a differential response to treatment depending on how steep your cornea is preoperatively. So if your corneas are very steep, more than 58 diopters Kmax, you're going to see massive flattening. So these patients actually, they see an improvement in uncorrected visual acuity after cross-linking as well. And this is a patient with pre-Kmax values of 46. And 1 year down the line, there was a flattening and improvement in best corrected visual acuity. Another patient who had steep Ks of 59 diopters preoperatively, and 1 year down the line, the patient had 55 diopters steep K, so about 4 diopters of flattening. Another patient with massive flattening in the central of the cornea. You can see preoperatively that readings are 73, 70.7, and so on. And a year post-op, the patient is in 60s. So patients are very happy. Their uncorrected visual acuity improves. As I mentioned, you can change the protocol to high fluence or accelerated cross-linking. To 30 minutes at 3 is what we do usually. You can change it to 5 minutes at 18 or 3 minutes at 30. There's only one paper in IOBS published that shows that you should not try and not go below 10 milliwatts per centimeter square if you want to see adequate impact of cross-linking. We published a study about 8 years ago showing that there is actually no difference in conventional and high fluence cross-linking, except the flattening that you see in conventional cross-linking is about 1.6 diopters compared to about 0.5 diopters with high fluence cross-linking. A bit about transepithelial cross-linking. As I mentioned, there are advantages of leaving the corneal epithelium on, but we've shown in animal studies and now in human studies as well that at transepithelial cross-linking, the flattening effect is not great unless you have a very steep cornea. So we repeated the same study in transepital cross-linking and found that if you have a steep cornea, you can still get adequate effect of cross-linking. This video basically shows a new software in Corvus. Basically, the red and blue corneas are pre and post cross-linking. And the difference in indentation, the CDR, corneal deformation response, shows the impact of cross-linking on these corneas. So really useful to have this device in your clinic. Quickly about keratoplasty, everybody in the room knows there are distinct advantages of performing a partial thickness endothelium sparing lamellar keratoplasty. Whenever possible, we try and do a lamellar keratoplasty, whether it's DLK, DLK, or LK, manual, femto, whatever you want to use. Try and not do a full thickness transplant because these patients are young. They're bound to have at least one rejection episode during their lifetime. DLK works very well. All studies, I was lucky enough to publish with my mentors from RP Center. Just to conclude, early diagnosis of keratoconus and timely treatment is very important to avoid transplantation. And you can use contact lens fitting, which I did not touch upon. Corneal biomechanics, they provide an avenue for enhanced diagnostics. A combination with corneal tomography, the BAD score and other score, it gives us an opportunity to look at the pathogenesis of keratoconus as well. Collagen cross-linking is a definitely promising technique, especially in younger patients where you can slow down or stop the progression of keratoconus at an early stage. And lamellar keratoplasty should be a definitive choice wherever possible for keratoconus instead of full thickness transplant. Thank you very much for your attention.
Can I ask a question? Thank you. Vishal, thank you for a very nice presentation, but I'd like to ask you about the recross-linking. Did you recross?
Yeah, so I haven't recrossed too much. You have to work at a place for about 20 years to see these patients. I can tell you, unless you're doing pediatric cross-linking, you might not need to recross-link them too many times. The usual time is about 5 to 7 years when you might need to recross-link them.
Yeah.
Yeah, so okay. I'm sure you probably have more experience than anyone else in Egypt with cross-linking.
Yeah. By which mean of investigation you can judge the cornea biomechanics, or you believe in the line, demarcation line?
Yeah. So we've stopped looking at the demarcation line now. Yeah. We don't care much about demarcation line because you can see the demarcation line after every cross-linking. Yeah. And the depth really doesn't matter because we already know that the demarcation line is deeper in conventional cross-linking compared to transepithelium, transepital cross-linking.
Yeah, exactly. Yeah. So about the recross-linking, it depends upon the stromal elevation or the stromal case to avoid the epithelial changes. Then it's available now in some devices like the MS39. I have it in my center.
Yeah.
So I'm following this with the stromal changes, the stromal case, not the front case.
Yeah.
Because it may be changed by the epithelium itself. If there is change in or change in the total thickness of the stromal part of the cornea, I will recross again.
Sure.
Otherwise, no.
Thank you very much.
Thank you so much.